Great. So let me just start off with some disclosures. My work at the WAI and WADRC, which I'm just absolutely delighted to be part of both of those, is supported by funds from the Wisconsin Partnership Program, from the National Institute on Aging, and from the U.S. Administration on Community Living. Um, as Suzanne and Cindy have noted, I've talked about this and related topics in other contexts, and so have received honoraria for those talks. So that's listed here. And then I get book royalties from the American Psychiatric Association. I will be, so that book is Behavioral and Psychological Symptoms of Dementia, and I bring it up only because I'm going to refer to it here. You'll see it in the references below. Okay, so we're going to keep this pretty streamlined. I'm going to really focus on the treatment side of things. And so a couple of objectives. The first one is to develop an approach to managing patients with behavioral and psychological symptoms of dementia. And that approach is going to include behavioral and environmental approaches first, and psychotropic meds secondary. And then where we'll spend kind of the bulk of our time is on that secondary part, which medications and why and how to start and how to stop and that sort of thing. So I'm not going to, as I've done in other contexts, kind of go into great detail around like epidemiology or why do behavioral symptoms arise or what are the different symptoms at different stages or things like that. I'm going to very quickly cover some of those background things and really move into management. So just by way of background, you probably heard me say before that behavioral and psychological symptoms of dementia, or BPSD, are very common in dementia. So about 90% of people will have clinically significant behavioral and psychological symptoms of dementia sometime between diagnosis and death. In fact, looking back at earlier criterion sets for Alzheimer's disease, like going back to the 80s, behavioral changes were part of the criteria. Now, of course, it's primarily cognitive issues plus functional impairment, but historically, behavior has been recognized as a problem in Alzheimer's. And in fact, going back to the original case of Augusta D, described by Alois Alzheimer, she was admitted to a psychiatric unit where she stayed for 5 years because she had paranoia, agitation, so she had classic BPSD. This is a core part of the illness. So the behaviors are common, they're problematic, they cause distress, they can cause safety issues, they may lead people to be hospitalized or seek higher levels of care or need higher levels of care. So they're significant, they're clinically significant, and they're significant from a public health perspective as well. So our approach in general is to get rid of medications, ideally. Deprescribing is one of my favorite things, and instead focusing on behavioral and environmental interventions, and then adding medications only in situations where the behaviors or the other symptoms are dangerous to the patient or others, or distressing. Things like depression and anxiety tend not to be dangerous unless the person also develops suicidal ideation, but they are distressing. It's not pleasant to be depressed or to be anxious. And so under that distress criterion, you could also justify using psychotropic medications. So that's what we'll spend most of our time talking about is selecting among those medications. So just one more background slide, and that's on prevalence. So again, looking from diagnosis to death, how common are the different behavioral symptoms? And this gives me just a bit of a chance to inventory them and then also just makes a few comments about the different behaviors. So first off, what jumps out, at least for me, is that apathy is the most common behavioral and psychological symptom of dementia. And this is especially true as you move into later stages of dementia. And personally, it was something I really didn't pay a lot of attention to, or I thought it was depression mostly. But it's different from depression. It presents differently and it has a different treatment outcome. And though apathy is almost by definition not distressing to the patient, they're apathetic about their apathy, it can be quite disabling because they're not participating in activities of daily living, and it can be very frustrating for family members and for caregivers. So I really try to sort of keep my ears open more for apathy. And it's different from depression in that apathy lacks that sense of sadness, distress, hopelessness, suicidal thinking that goes along with depression. There tends to instead to be an indifference and kind of a coarsening of behaviors. People are less interested in the nuances and social pleasantries of conversation, and so they may come across as kind of crude, not because they're intentionally being mean or anything. It's just because that's just something that doesn't interest them any longer. As opposed to depression, people are sad, they're crying, they feel guilty, worthless, hopeless, helpless, kind of all the cognitions of depression. And the treatments are different, especially the pharmacological treatments, which we'll talk about in a moment. But briefly, it's antidepressants for depression, and maybe if the benefits outweigh the risks, stimulants like methylphenidate for apathy. So those are actually the top two most common behavioral and psychological symptoms. The one that gets probably the most attention because it's so disruptive and potentially dangerous is aggression, especially physical aggression. So its incidence peaks in moderate stages of dementia. And then kind of fades off a little bit after that. Sleep issues are very, very common. I imagine you heard some of that in Dr. Seeger's presentation, especially around Lewy body disease, a lot of REM behavior disorder, for example. But we see plenty of sleep disruption in Alzheimer's disease as well. I won't go through every single one of these. Let me pick and choose here a little bit. Delusion. So most common delusion is of theft. Typically what's happened is someone has misplaced something, they've forgotten where they put it, and then they accuse someone else of stealing from them. Next most common is this is not my home, you stolen me away someplace. And that's typically a memory issue as well. They've forgotten that they moved to an assisted living facility, for example. And the third most common is delusions of infidelity. Those are the delusions that are typically seen. Hallucinations are less common. They're the hallmark of something like Lewy body disease. They're less common in Alzheimer's disease. They tend to be visual hallucinations, although they can be auditory or tactile. And with Lewy body disease, the classic visual hallucination is it's super vivid. It's people can. I'll tell a story. I don't have a lot of time, but I love to tell stories. So a few weeks back, I was seeing a patient who it was a video visit with her and her husband, new evaluation, and she had Lewy body disease. She also had a lot of urinary frequency, so she was up and down quite a bit during the visit to use the restroom. And she came back from one of the visits and said, I think this was a hallucination, but I saw a woman with purple hair. She was between ages 18 and 28, and she was going through my purse. I don't know what she was doing, why she was doing that, but she was going through my purse. So like incredibly vivid, down to like, the purple hair and the age range of the patient. So that's just so classic for Lewy body disease hallucinations. The hallucinations in other dementias tend to be kind of less well-formed, less clear cut than that. So there are other BPSD, and we'll kind of touch on some of them later on, but those are the main ones to focus on. Okay, so that's all the background stuff. We're just going to dive right into management. Kind of broad principles. So first off, look for and address medical issues that might be contributing. So that includes things like chronic pain or acute pain for that matter, constipation, dehydration, visual impairment, hearing impairment, electrolyte imbalances, maybe UTI, that's a little controversial, sleep apnea, like especially if someone has apathy or depression. So look for, we heard just a moment ago, B12 deficiency, thyroid disease. I mean, all those things can contribute to BPSD. So look for those things and address them if they're present. We also look very closely at the medication list and think about medications with anticholinergic properties, which could contribute to hallucinations, to paranoia, to confusion, to depression, to anxiety even. Other psychotropic medications, antidepressants can cause anxiety, can cause irritability, can cause agitation, can cause insomnia. Antipsychotics certainly have plenty of psychiatric side effects as well. Opioids, benzodiazepines. So, Parkinson's agents. Dr. Seeger and I have many patients in common where we're trying to balance out the meds for the motor side of things with the medications for their hallucinations, which might counteract each other somewhat. So taking a good look at that medication list. Oh, alcohol would be another one. So not surprisingly, alcohol is not great for BPSD. So stopping alcohol would be a nice touch. Cannabis, probably not super great for BPSD. So stopping that or not starting cannabis would be good too. These are stressful situations for family members, so providing them with support and then developing a plan that is primarily based on behavioral modification, environmental interventions, education, and support of the caregivers. And in general, we try not to add medications if we don't have to. And if we do add medications, monitor outcomes closely and really go in with a plan for how am I going to stop this medication eventually. So not viewing any new medication as something long-term, but as something that's going to have an end date at some point. And we'll talk about that, especially with respect to antipsychotics. So I just want to spend a bit of time. I'm going to have a little bit of a mixed message here. I'm going to, it's don't do meds, but I'm going to spend most of the talk on meds. So I do have these couple of slides here on non-pharmacological approaches, or more positively, behavioral, environmental, psychological approaches. So really, actually, these have the best effect sizes, especially. And the thing that has the best effect size, the largest effect size of any intervention for BPSD is formal training programs for paid caregivers of people of dementia. So you can see effect sizes of like 1.2, 1.3, gigantic effect sizes. The challenge is it doesn't come in a pill form, and so it's difficult, it's expensive, it's time consuming. So there are practical issues around implementing staff training is basically what we're talking about. But that really is the most effective intervention we have without side effects, in particular to the patients. So, and then there are a number of other evidence-based psychosocial, environmental, behavioral interventions, including just adding more structured activities, music, especially for acute agitation, multisensory stimulation. Snoozolin is a model wherein people kind of interact with this multisensory kind of device or room. There's some lights and sounds and tactile things going on, and so on. There's some data to support reminiscence therapy, especially for depression, and then same for problem-solving therapy. Problem-solving therapy is kind of a version of cognitive behavioral therapy that is modified for people with memory loss. Again, the most effective interventions are formal training programs. The one that we've used extensively at the Wisconsin Alzheimer's Institute is DICE, which is symbolized by these cute little dice coming out of a pill bottle. So that's describe, investigate, create, and evaluate. So, describe the behavioral symptoms, investigate what might be going on, create a treatment plan, evaluate the effectiveness of your treatment plan. So it's a whole structured model available online now. So we've been using it online in a couple of our studies to train caregivers of people with dementia. And then in the family setting or family caregiver setting, there's some evidence that training and supporting them may be a benefit as well. So interestingly, so most of the studies have been in long-term care. So if you're trying to use these interventions in other settings like people's homes, you can do it. There's just less evidence that is going to be effective. Many of these interventions have not necessarily been sort of designed and tested in culturally diverse populations, and so these things may need modification depending on the patient that you're working with and their cultural and racial and ethnic background. All the non-pharmacological interventions are going to require time and patience, and especially like the staff type of interventions, they're going to be time consuming. And of course, everyone's going to need an individualized plan. There's really no things like DICE provide a framework, but ultimately each person is going to need their own treatment plan. So if you've done all that and there are still really significant distressing symptoms or behaviors that are dangerous to the person or others, that would provide justification for using a medication. And the main reason we wait is because none of the meds work great. Effect sizes are not great, certainly much smaller than that 1.3 effect size I quoted earlier for staff training. And the side effects are pretty significant, in particular with antipsychotics. And there's the additional issue of it's usually not the patients themselves providing the consent. It is sorry, I was a little distracted because my watch told me I just met my stand goal for the day, even though I'm sitting here. So anyway, bad watch. It distracted me and it's wrong. Anyway, let me get back to this. So the complicating thing here is you've got to talk to a family member or some other surrogate decision maker as well. The person themselves may or may not be able to participate in this decision-making process, in particular if they're agitated. So, just basic kind of geriatric psychopharmacology for all of our meds is to start low, to go slow. And sadly, every single drug that I prescribe is on the Beers list. I checked the most recent one. There are like different boxes in the Beers list, different categories, and it's all there. I mean, anyone you name, you just shout one out, and I can just tell you the answer. It's on the Beers list. So, in other words, there are significant concerns about using any psychotropic medication in an older adult. So this is a bit busy, but it's kind of the orientation for the rest of the presentation, which is kind of thinking about what are the specific symptoms and how might we approach them pharmacologically. So with psychosis, it's typically antipsychotics, which we'll talk about in a moment. If the person has Lewy body disease, it would not be antipsychotics. It'd be donepezil or another cholinesterase inhibitor to help with their paranoia and vivid visual hallucinations of ladies with purple hair rifling through their purses. Trazodone, there's some evidence, probably more so for agitation than psychosis and frontotemporal dementia. Prazosin, same thing, probably more agitation than psychosis. And then there is an FDA approval for pimavanserin or Nuplazid for Parkinson's disease psychosis in particular. Agitation would share that list, and then you'd also add SSRIs to the list. And citalopram does remain the gold standard. We're still waiting, as best as I can tell, on S-citalopram results. When I gave a version of this talk in February, Dr. Asthana alluded to there being some S-citalopram data. I have not been able to find it. I keep looking on clinicaltrials.gov and elsewhere for the outcomes. There's a large S-citalopram study that we're waiting on the results for. The thing there is we'd be hoping that S-citalopram may not have the cardiac issues that citalopram does. The data on sertraline is not super, and I think I have a later slide on antidepressants. I'll get back to vortioxetine because there is some interesting data on vortioxetine, which is new. For apathy, the best data is for methylphenidate, but methylphenidate can be problematic from a cardiac perspective, especially tachycardia and hypertension, or if the person already has an arrhythmia or a recent heart attack or stroke. For insomnia, the data is not great. I reviewed the literature on this recently, and the non-demented population, there's a wide range of things we can use. In folks with dementia, it's quite limited. We use trazodone, but the data is not super supportive. Melatonin may have a role for REM behavior disorder, but probably not super effective beyond that. And in general, we avoid benzos, but there is one niche, and that's clonazepam for REM behavior disorder. For wandering, there's a little bit of data on risperidone. I would much rather use non-pharmacological measures for wandering, but there's some data that a modest dose of risperidone, like no more than 1 milligram a day, may help with wandering. For pathological laughing and crying, there is an FDA approval for dextromethorphan quinidine combination, or Nuedexta. And then we sometimes see folks with sexually aggressive behaviors, and there's kind of more of a, a variety of options, including trazodone, carbamazepine, SSRIs for men, estrogen therapy, and maybe antipsychotics. So not super great evidence on any one of those things, but those are some of the things we might try for more sexual behaviors. Sexualized language, you'd want to respond in a non-pharmacological way. Sexually aggressive behavior would make more sense to try a medication out. Antipsychotics. So this is the current list of antipsychotics where we have any sort of data in BPSD. So the most data is on risperidone, olanzapine, and aripiprazole, with very mixed data on quetiapine, very little data on clozapine, although that's the gold standard for severe psychosis due to Parkinson's or Lewy body disease. Brexpiprazole. I thought after the black box warning that no manufacturer would ever try to use antipsychotics again in BPSD because of, death. But someone, whoever makes Brexpiprazole or Rexulti, decided to go for it. And so there actually have been a couple of trials showing some evidence of efficacy. It's not necessarily any better than any other antipsychotic. And I think the last time I prescribed it, it was $500 a month. So it's certainly much more expensive than risperidone or olanzapine, say. But there is, it's another option potentially. And then of the typical antipsychotics, Haldol has the best data, but we really try to avoid using Haldol. Acutely might make sense. Delirium, it might make sense very briefly, but in the long run, the cardiac and mortality issues are worse with haloperidol than they are with the atypical antipsychotics. So I just got on one slide, all the side effects. So we'll just start with the big one, death. This has been true for quite some time now. So the original meta-analysis found that antipsychotics are associated with a risk of mortality of about 3.5% in the first 12 weeks of being on the antipsychotic, placebo 2.2% in the first 12 weeks. Cause of death is typically either cardiac, perhaps due to QT prolongation, and or pneumonia due to aspiration, because these drugs are sedating. There can be other things too, like stroke, maybe DVT and PE, fall, and complications of that. But cardiac and pneumonia are the big ones. Sedation, very common. Cognitive impairment, which is, real bummer. We're treating cognitive disorders, and these meds worsen cognition. Extrapyramidal symptoms, so especially with haloperidol and risperidone. Falls and fractures, so any psychotropic will increase your risk of falls, and that's certainly true of the antipsychotics. Metabolic issues we don't worry about a ton, but that could exacerbate some underlying dyslipidemia or hyperglycemia, especially with olanzapine. Stroke, there's increased risk with risperidone. And then, things like DVT. I see a lot of edema, actually, tons of edema with antipsychotics. Neutropenia with clozapine in particular, although you can get it with others, and then DVT is a possibility. So boatload of potential problems with the antipsychotics. And the benefit side is not great, to be honest. It's weird because clinically it seems like these work well, but in rigorous clinical trials conditions, it's actually very hard to show that these separate from placebo. And when they do, it's not huge effect sizes. Like, what I quote here is 0.16, which is super low. The number needed to treat is 6. So if I give 6 people brexpiprazole, say, and let's say they all get better, only one really got better because of the brexpiprazole. The rest, it's placebo effect, passage of time. non-specific things like the staff are paying more attention to the patient or whatever. So, not really great efficacy. But these are the drugs that have by far and away the strongest evidence-based number of subjects, number of studies for psychosis and agitation in dementia, in particular dementia due to Alzheimer's disease. Lewy body is a different story. You really want to try to avoid antipsychotics, go with the cholinesterase inhibitor if you're going to use something, maybe clozapine, maybe a pimavanserin, but really trying to stay away from the antipsychotics in Lewy body disease. The dosing's very low, much lower than for younger people who have schizophrenia or bipolar disorder. If the drugs don't work, we should stop them. That seems obvious, but there are lots of patients who just sort of end up on these medications. And even if they do work, still stop them. The usual recommendation is about 4 to 6 months after starting to start getting, start tapering off, start doing your gradual dose reduction of the antipsychotic. And that's because the mortality risk persists for about the first 3 years after starting the antipsychotic. It's not just the first 12 weeks. So what else can we do? Well, we can do some antidepressants. Not for psychosis, maybe for agitation, and perhaps for depression and anxiety. Citalopram still has the best evidence base, 30 milligrams a day. That is the dose that's also associated with QT prolongation. May or may not be clinically significant. Most of the time I'll check an EKG and either the QTC is normal or it's gone up a little bit and it's really not that big of a deal. Escitalopram might be an effective alternative without QT prolongation, but we don't know for sure. And the data on sertraline is really pretty mixed, which is a bummer because it's a super well-tolerated drug and it doesn't have cardiac issues, so it has a significant advantage over citalopram. So if someone does have pretty bad cardiac disease, I'll just go with sertraline if I'm choosing an antidepressant. I do have some newer info to share, and that's on vortioxetine. So vortioxetine is basically an SSRI, but it has some additional efficacy on a kind of more recently characterized serotonin receptor. It's the 5-HT7 receptor. Supposedly, there are some cognitive benefits that are mediated by vortioxetine's action at the 5-HT7 receptor. And what's interesting is vortioxetine has actually been pretty nicely studied in people over 65. So often what happens is you get an antidepressant, it's usually 18 to 65 is the group that's studied, and sometime later on we start studying these in older adults. Vortioxetine came to market about 5 years ago, and there have already been a number of studies in older adults. So, pretty safe, pretty well tolerated, and there does appear to be some cognitive specific benefit. And so we are now in the last year or two seeing some studies specifically looking at vortioxetine in people with cognitive impairment. So vortioxetine is expensive because it's newer. It's often behind massive walls of prior authorizations. So I get to prescribe it because I'm seeing patients who have failed umpteen antidepressants, and so I can make a case to try it. If it's the first or second antidepressant, it's probably going to be a no-go from an insurance perspective, so you may have to try a couple of others first. So that's new, and I wanted to share that. The other new development is on bupropion. So bupropion and methylphenidate were kind of the gold standards for apathy. But there was a trial earlier this year that showed bupropion did not separate from placebo for apathy, which is a bummer because bupropion is better tolerated. It's a safer drug than methylphenidate. So I'll still use it, but I'll be sort of more skeptical about whether the bupropion is actually going to be effective or not. So we avoid paroxetine because it's anticholinergic. We avoid tricyclic antidepressants because they're anticholinergic as well. There are some safety concerns to be aware of with antidepressants. So all the antidepressants except for bupropion can cause hyponatremia. And there actually have been some case reports with bupropion as well. So if someone's prone to hyponatremia anyway, I'll just follow their sodiums. If they're on a diuretic, I'll follow their sodiums. The risk factors for SSRI-induced hyponatremia are female gender, age over 65, and being on a diuretic. So the more of those they have, the more rigorously I'll follow their sodiums. And you'll tend to see sodium drop a little bit, like it might go from 136 to 133, so that's no big deal, but it could drop more significantly than that. QT prolongation can happen with citalopram, could happen with trazodone too, for that matter. Usually the other antidepressants are pretty safe in that regard. You can get falls. The main issue is really GI stuff, especially, weight loss. So, GI distress can manifest as people just not eating and losing weight. And of course, that's problematic in someone with dementia. So if we start in SSRI and then they start, being less interested in food, then, I'd probably revisit the SSRI and whether that's a good idea or not. That might be a place where then maybe you go to mirtazapine, because it generally does not have GI side effects other than some constipation. Okay, so what else? So little laundry list here. So acetaminophen. So I prescribed a lot of acetaminophen. There's a lot of pain in people with dementia. Acetaminophen is safe. It's well tolerated. 1,000 BID or 1,000 TID for basically as a treatment for agitation, whether or not they're endorsing pain. Carbamazepine, we use very little of. The patients I have on it, they were put on it many years ago for bipolar disorder or maybe trigeminal neuralgia. But in general, we don't really use much carbamazepine. A lot of drug-drug interactions, lots of side effects. Clonazepam I've mentioned before. Dextromethorphan, so that's dextromethorphan plus quinidine equals Nuedexta. That's FDA approved for pseudobulbar affect or pathological laughing and crying. It's super expensive, so I've just used dextromethorphan alone. You do have to dose it 3 to 4 times a day. The quinidine is there so that you can dose it twice a day. If you get rid of the quinidine, it's cheaper and there are less cardiac issues. So I just use the dextromethorphan alone. I have a success rate of 0.00% with dextromethorphan. I've just never been able to get it to work. Maybe because I've sort of thought of it as like the 7th medication and it's not likely to work. We talked about donepezil, gabapentin, not much evidence to support its use. Avoid benzos for lorazepam. Melatonin, REM behavior disorder, sure, probably not useful for much else. If you do use it, just dose it right. It should be about 2 to 3 hours before bedtime. And I don't think you really need much more than 3 milligrams a day. Memantine does not work for behavioral disturbance. If you use it, it's really more for, preserving cognition. Methylphenidate. So now with the bupropion drug study, it's really the gold standard for apathy. It is a really careful risk-benefit discussion because it's not trivial side effects. The mean millimeter mercury increase in blood pressure is 17 in people at the higher dose of methylphenidate. So it's, it can be a big deal. The good news is if you run into trouble with it, you can stop it and it'll wash out of the system very rapidly and you're done. So I have used it more over the last 5 years or so with some success. Pimavanserin, I mentioned earlier, prazosin. So there's one small study that's being replicated now. It's taking forever for them to recruit. So it's been a few years that they've been running this study now of prazosin. So the original small study was from like 2008 or 9. Small study showed benefit for agitation. The theory is you're sort of reducing noradrenergic drive. And so now we're waiting for the replication study. I've used it. I've especially used it in people with anxiety, if they have like a PTSD history, and I wonder, well, maybe their agitation is sort of a PTSD manifestation. They have a lot of insomnia, and it can be helpful. It's an alpha-1 blocker, of course, you got to watch blood pressure. Really not much role for Depakote. It's repeatedly been shown to be not effective for BPSD. Every once in a while it works. I had a patient who's been hospitalized a bajillion times and not doing well, and she got hospitalized and got put on valproate, and she's doing great now for her agitation. So, it may work, but in general, the evidence base is pretty strongly against valproate.